Professor Radhika Tandon to talk to us on the basics in collagen cross-linking and its clinical applications.
Thank you, Vanati. Thank you for giving the opportunity to present in this instruction course. And as you said, I'm going to show you some videos as to the practical aspects. Not going too much into detail about the case selection and so on, but just a quick recap that we will do a thorough clinical examination with the help of imaging modalities, corneal tomography and anterior segment OCT. In selected cases, confocal microscopy and corneal biomechanics as a basic workup and genetic analysis when indicated. When we have documented progression, one would consider for collagen cross-linking, and this is the standard generally accepted limits, one would say, as a guidance for decision making. Having said that, there are patients who one would like to consider collagen cross-linking straight away. For example, they may be young patients, they may be already a history of previous progression, or they may not be able to come for follow-up. Now, the technique of corneal collagen cross-linking, few things that I would say would be specific to our protocol, that with the reports of infectious keratitis and having seen 2 cases of infectious keratitis following cross-linking for patients of VKC and keratoconus, what we do now is we consider patients who have had VKC and keratoconus as at risk of having an abnormal ocular surface composition. So we do a pre-operative conjunctival swab. And the other thing is that we don't give the topical steroids immediately after surgery. Let the epithelial defect heal and then start the steroids. Regarding the conventional cross-linking or Dresden protocol, we've generally shifted to the accelerated protocol now. Just see if I can get this video to move. So it's simply that it's shorter and more convenient, and also it's been shown to be equally effective. Regarding epithelial debridement, there are various techniques. One could use a blunt trephine, or one could use an alcohol well, and would apply alcohol and then gently remove the epithelium, trying not to scrape the stroma, because every mechanical injury or insult you produce to the stroma is going to lead to a reactive inflammation. So try to be very gentle. And then one would use, again, there is a tendency for some people not to use the customized dropper which comes with the serum, because it's quite thick, and sometimes if you're not careful, a large volume comes out, so people tend to replace it with a simple cannula. But I would say advise against it. Use the customized dropper, because you do require that thicker drop, and you do require it to soak and completely bathe the cornea so that it seeps in. Coming to, and then we insert a bandage contact lens at the end of the procedure. Here is another example of surgery. The alcohol well is what I prefer, but sometimes it's not available, and one could use a manual trephine. Apply it for 30 seconds is what's recommended, but I extend it to 40, because often these are very young patients and their epithelium is a little bit more adherent. So at the end of 30 seconds, do your slow countdown and start soaking out the alcohol using a mirror cell sponge. So effectively, the contact time is 40 seconds. So if you apply it for less than 40 seconds, there are islands of epithelium which are still attached, and then one would have to use a blunt instrument to gently move it away. And then, of course, one would apply the riboflavin, and then the mirror cell sponge, remove the epithelium, and then apply the UV radiation. Now, the technique of accelerated cross-linking, and there are again different protocols, and depending upon the corneal thickness, you would decide whether to use a hypoosmolar or isoosmolar. In thin corneas with less than 400 microns, one could also use, generally our preference would be, if it is about 380 to 400, use the hypoosmolar solution. Otherwise, one could use a bandage contact lens or a smile lenticule assisted technique. And of course, now for the thin corneas, we have the customized protocol of adjusting the time and the duration. So one more video to show. Okay, this one's not playing. 1 second. Just see if you can play the video. Yes, so here applying the alcohol well, you have to explain to the patient that this is what's going to be done. They shouldn't suddenly get nervous and jerk or move the eye. Put the drops of alcohol and then ideally use a Mirocell sponge, but in this particular case, the simple cotton swab is being used to soak up the alcohol. Do it little gently. The little layer of alcohol which is allowed to stay for that extra few seconds. I can see in here it is coming out a little bit more easily compared to the previous case. So that is the tip that will come from me, that keep it for about just under 40 seconds, remove the epithelium, again taking care to manipulate the epithelial side and not scrape the stroma vigorously. And then the riboflavin is applied, and then the application of the UV light. So there are certain indications, borderline corneas, where one is going to go for cross-linking, one is going for a refractive surgical procedure, and one would top it up with cross-linking, what we call LASIK extra. This is an example of a 27-year-old patient who was a student by occupation, and he wanted to go for he wanted refractive surgery because it was required for him to clear the exam and the medical exam for his job, which happens in many cadres of professions in India. He had no other problem, no known eye allergies, etc., no history of contact lens wear. So this was his these were his refractive findings. You can see it's little higher refractive error, but his maps and topography were fine, so he was cleared for treatment. And the Corvus biomechanics also showed that his parameters were all within the stable zone. He was having, with the calculation, a residual bed thickness of 310 microns. The PPT was also within the range. The ablation was going to be 105 microns, and the expected post. So all the parameters were stable and safe. But we decided to do a 90 microns flap because other procedures such as ICL were not accepted for that particular job, but LASIK was an accepted technique, refractive corrective technique. So now what are the indications for LASIK extra, that is collagen cross-linking supported corneal refractive procedure? As such, high refractive errors is one. Now that is a philosophical point of view. It's not that we do it for every case, and we don't follow that. But in the studies of LASIK extra, this was one scenario which was mentioned. Borderline residual stromal bed thickness, again, this is again debatable whether one should be recommending it for every case. Thin cornea. So this is what I would say, if it is 475, 80, 85 cornea and there's a low refractive error which is fitting within the range, that would be one indication. And again, high preoperative astigmatism, I wouldn't think of that. A higher percentage, this is another one. So it seems as if there is a push that you consider doing LASIK extra for a lot of these procedures which you would normally go ahead straight away. Our indication basically is that when it's really going across your safe limit, in this particular case, and in fact age below 30 years is a risk factor for post-LASIK ectasia. Everything else was normal in this case, but his corneal thickness, this was the point 481 to 510, and looking at the number of risk factors. So the procedure, you create the LASIK flap as normal, and then at the completion of the ablation, you apply dextran-free riboflavin formulation on the bed, put the flap back, and then expose the eye to the UV light. I'll quickly show you this video of this patient. So here the duration of soak and the duration of treatment is less. That is because it's supposedly a healthy cornea. It's a prophylactic treatment that one is doing. And here the flap is being lifted and then the ablation is being done. Subsequently, one would apply the riboflavin drops. Here I did not use that thick dispenser because I wanted to control where the drop was falling, didn't want it to flood the flap also. And then after that, after the application, you irrigate, put the flap back on, and here be mindful of the fact that the riboflavin is going directly on the stromal bed, so it's going right where you want it, as opposed to the others where it's going right through, and that is why the lesser duration of soak and then the lesser duration of treatment. And then we have now acquired this machine for the LASIK suite exclusively so that we don't disturb the normal operating time. And then the UV radiation is applied and then a bandage contact lens put. So this is the parameters. Just a quick word that what is recommended with this particular Peshke machine is a particular type of riboflavin as is reported. Now that is not available, so we had to use the riboflavin from another company. It's all right because basically we follow the same principles, but this is something more that one needs to be aware of. You see something which is reported, something which has been published with a particular scenario, and then you have to modify to another depending upon what's available. So one has to always consider this when one is doing any procedure, that you may not be able to exactly match what has been reported in the published study. So this is again what I'm illustrating, that it will depending upon which kind of machine you're using, which drops you're using, what is the patient. So it's not something to be taken extremely lightly. Just one more video I have of cross-linking for infectious keratitis. Topical anesthesia, central cornea 7 to 8 millimeter zone is very gently debrided. Then the riboflavin solution is applied and then irradiated. This is a preoperative picture. Here again we have the riboflavin solution, and then we have the Peshke machine, and then the eye is radiated, and there are variable results. One could not say that it is a universally acceptable procedure. So with that, I'll stop here. I invite you all to participate in the Comprehensive Cataract Conference that we're hosting later this year, 7th to 9th November in Delhi. Thank you very much.
Yeah. Thank you very